Kia ora koutou. Nei rā te mihi atu kia koutou, nau mai haramai. Welcome along to this presentation. My name is Hector Matthews. I work for the Canterbury District Health Board as the Executive Director of Māori and Pacific Health, and I'm going to talk to you today about equity, or more specifically Māori health equity and inequity, and to shine a light on some of the issues that occur within our New Zealand health system. But before we begin, I'd like to introduce myself in Te Reo Māori. Kia ora tātou, ko whangatawatia te maunga, ko kāriri kura te moana, ko ngā toki mata whaorua te waka, ko ngā timoraki te hapu, ko te rarawa te iwi, ko korau kore te marae, nō reira tēnā koutou katoa. Kia ora everyone, I hail from the iwi of Te Rarawa in the far north, and it's my privilege to kōrero to you all today. Before we get into the presentation proper, just a few little points, a little bit tongue-in-cheek here, but something to remember that we're all adults here, and some of the language that you may hear, you may not understand. It could be in Te Reo Māori, but many of the things that I'm going to be talking about today can actually be quite confronting. So we have to get comfortable with the discomfort. And if you feel uncomfortable, there's an old Māori whakatauki, tū whitia te hopo, which means banish your fears. Just set that to one side and get comfortable with that discomfort. Okay, so let's talk about, firstly, the determinants of health, because in any discussion that one has about inequity, be it inequity of health based on age, disability, ethnicity, whatever it may be, there are a whole range of things that impact on health and our health outcomes that are known as, collectively, the determinants of health, the things that determine our health. And this diagram here is adapted from the Institute of Clinical Systems Improvement in 2014, and the Ministry of Health have used this in their Health and Independence report. So it's widely accepted in the New Zealand health system about the determinants of health. So we need to understand that there are many, many factors that affect our health, and they are collectively known as the determinants of health, and they can support or be barriers to good health and broader well-being. Key amongst them are socio-economic factors, your education, your income, things like your job, and then there are physical environments, things like the home that you live in, whether it's cold and damp and safe and those sorts of things. And also our health behaviours, whether we drink alcohol, take drugs, whether we have a sensible and nutritious diet, how often we exercise, tobacco use, etc. Those collectively impact significantly on our health. And those are things that for those of us that work in the health system can't directly affect. So it's very, very difficult for us to take responsibility for things that we can't directly impact on. We can influence them, we can promote good health and good diet and good exercise, we just can't directly impact on them. However, another key factor of the determinants of health, about 20% of the factors affecting health outcome are quality of healthcare and access to healthcare. And those are the things that I'd like us to think carefully about now, because those are the things that we can directly impact on. We can impact on the quality of care that we provide for our people and the access to care that people receive. And from the perspective of Māori, we can impact on the quality of care that Māori receive and the access that Māori have to our health system. So that's a really important part of this presentation, and understanding equity and how it impacts on us as a population. So let's firstly begin at understanding what it is I'm talking about when I talk about Māori and the New Zealand Māori population. So at the 2018 census, there are around 776,000 people that identified with the Māori ethnicity. That's a significant increase year on year. It's more than 5% growth in the Māori population from the 2013 census to the 2018 census. Approximately 16.5% of New Zealanders identify as being Māori, and that's about 1 in 6 people. 1/3 of those are under the age of 15, and the median age is 25.5 or 25.4 more correctly, compared with 41.4 for Europeans. So that's a significant difference in the median age. And just to put that in perspective, I'm 55 years old, so I am more than double the median age for Māori. So as a Māori, I'm actually a very old Māori. If I were European, I wouldn't be particularly old, only slightly over the median age. So it's a very, very different looking population to the general population and indeed the European or Pākehā population. And we need to understand that when we're looking at health services. So again, continuing on with the New Zealand Māori population, as I said before, 16.5% of the New Zealand population is Māori. But if you look at this graph here, it represents graphically how very different those the ages of that population is. The vast majority of the Māori population are sitting in that under 25 group. In fact, 1/3 of them are under the age of 15. And yet when we look at the European population, it's significantly different. And then you get to the older population group. Once you get over 70, you see almost no Māori are up there. Very, very small proportion of the Māori population are over the age of 70 compared with the non-Māori population. So in the middle, there are similarities in proportions, but at the very young ages and the very old ages, there are significant differences in the structure of the populations. A much lower life expectancy for Māori, less than 6% are over the age of 65, and yet it's 3 times more in the non-Māori population. And as I said before, very different age spread in terms of the age, the median age. So it's really important to understand when we look at our Māori population in New Zealand, they are not the same as the Pākehā population. They are not the same as the European or the general population. The Māori population is different. And if we assume people are the same, we will get it wrong for Māori. And actually there's lots of data to demonstrate that we have gotten it wrong for Māori all the time because we have assumed Māori are the same as everyone else, and they are not. So let's look at some of that data. What are some of the differences that occur in health outcome or health access for our Māori population? I've put the source of this data here. It's from the Ministry of Health's mortality report in 2016. Major causes of death. What we see here is all cancers, ischemic heart disease, cerebral vascular diseases, chronic lower respiratory conditions. In each of those, and all of those are significant killers in New Zealand and particularly in our health system, there are significant differences. So the mortality rate for the non-Māori population in cancer is about 110 per 100,000 of population versus 188 for Māori. So by a factor of about 70%, 2/3 higher for Māori in all cancers. It's more than double for ischemic heart disease. It's about 50% higher for cerebral vascular diseases and almost triple, it's about 2.5 times higher in respiratory or chronic lower respiratory diseases. What this is showing is that when Māori get unwell, they die at significantly greater rates. And so this highlights the importance of access to healthcare sooner and in more efficient ways for our Māori population, because there's no good reason why those mortality rates should be so much higher. Let's look a little bit more deeply into some of those. And again, this comes from the Waitangi Tribunal report, their health trends report published in September 2019. and this data here, or these data here, specifically look at cardiovascular disease mortality rates for 35 years and over by gender for Māori and non-Māori. So the blue line is Māori, the grey line there is non-Māori. We have men or males on our left and females on our right. And there's a few things that you can see here that men have had traditionally higher rates of the disease over time, but they are trending downwards. Everybody's rates are trending downwards. But as you can see in the early parts of this data here in 1998 through 1996 through to 1998, the gap between Māori and non-Māori was much, much greater. In fact, the age standardised mortality rates were twice as high for Māori, more than 700 for men, and around 500 for women, for Māori, versus just over 300 for non-Māori and men, and around 200 for non-Māori women. So the mortality rates were twice as high back in the late 90s. Everybody's rates have dropped over time, but actually those mortality rates still remain around double. So everybody's mortality rate has been dropping, and in fact, after adjusting for age, mortality rates have decreased by 50% between 1996 and 2014, but the Māori rates are twice as high when compared to non-Māori. So we haven't managed to close the gap on cardiovascular disease mortality rates, despite the fact that everybody's rate is dropping. The gap still remains. Now let's look at cancer registration. So these are the cancers that we know about, the people that have turned up to primary care or to the hospital, have been examined, have been tested, and we know they have cancer. 25 years of age and over, Māori and non-Māori, and on the left there are females, and on the right there are males. It's the age standardised registrations per 100,000 of population, and what we can see is after we age standardise, there's a slightly higher registration rate of cancer for Māori than non-Māori over time, but it's only slightly for females. It's around 400 per 100,000 of population, and for Māori it's around 500. So it's slightly more, about 20% higher, but not significantly so. And for men, a similar sort of thing, around 400 for non-Māori, and in fact just under 500 for Māori. So there are slightly higher rates of registration for cancer over that period of time from 96 to 2015. However, when we take those same people over the same period of time and look at the mortality rates, what we find is Māori die at a significantly greater rate. There are significantly higher rates of mortality. So these are all the cancers we knew about, which is deeply troubling over such a long period of time, because what it's pointing to is either Māori aren't receiving the same care or the same access to care. So despite the fact that the registration rates are only slightly higher, the mortality rates are significantly higher for cancer. So what this is showing is that our system isn't performing as well for Māori. We've made some gains over recent years, and we saw some of those registration rates dropping. We saw some of those incidence and prevalence rates dropping, but the mortality rates still remained much, much higher for Māori. There are stark differences in access to healthcare services for Māori and health outcomes for Māori versus non-Māori. There are these systemic assumptions about equality which exacerbate inequity. And a good example of that currently for cancer is our bowel screening program, which we are currently rolling out. Māori and non-Māori have similar registration rates. So the risk for Māori and non-Māori catching colorectal cancers is pretty similar. However, the mortality rates are much, much higher, and Māori catch the illness or get colorectal cancers about a decade sooner, but we don't get access to the services sooner. Our bowel screening program treats everyone the same, and we screen from the age of 60, and despite the fact that the College of General Practice and the College of Surgeons and the Māori Doctors Association and the Māori general managers from every DHB in the country have written to the ministry saying, if you treat everyone the same, you will ensure inequities persist. The ministry has chosen to ignore that. So the systemic assumptions about equality, about treating everyone the same, is actually exacerbating the inequity because people aren't the same. Māori are a younger population, they have a higher burden of disease and they tend to get those diseases much sooner and their mortality rates are higher. And we know this, and despite knowing this, we are still treating everyone the same. So this policy of treating everyone the same actually affords privilege to non-Māori in their access to services and their health outcomes. So it's no surprise that we see unequal outcomes. So we're in the middle of a pandemic. The world is in the middle of a pandemic, COVID-19, and I thought it might be prudent to talk about pandemics and COVID-19 and ask the question, because it's directly attributable to inequity. Why is equity so important in this pandemic, or indeed in any pandemic? So the best case to look back at for health inequity and for a pandemic in New Zealand anyway is the 1918 influenza pandemic. And there have been a few smaller epidemics around the world since then, but that's certainly the largest example and one which we have a lot of data on. So it was an extremely virulent pandemic, that influenza pandemic, with estimates of over 100 million deaths worldwide. So that's significantly greater than what we're seeing with COVID at the moment. The New Zealand mortality topped around 8,500 people. That's an awful lot of deaths when you think that we've had 25 deaths for COVID at the moment, and this pandemic's still got a long way to run. 8,500 was particularly tragic. And bearing in mind that our population was only 1.15 million, so it was less than a quarter of what we have now, and 8,500 deaths back at that 1918 influenza pandemic in New Zealand. The national mortality rate was 7.7 per 100,000 people, so almost 8 people out of 1,000 people died of that flu pandemic in 1918. However, the Māori deaths were believed to be around 2,160, a mortality rate of 42.3 per 1,000 people. So around 6 times higher. For every non-Māori that died in New Zealand, 6 Māori died in New Zealand as a rate per 1,000 people. At the time, that was a third of all the Māori population were located in our poorest populations. And it's also generally accepted that the population estimates used for Māori to calculate those mortality rates were based on the 1916 census in New Zealand. And now we know that it was not as sophisticated as the methods we have now, and that those mortality rates are likely to be even higher than what's been recorded. So that was a particularly virulent pandemic, and there was significant inequity in infection and mortality for Māori back then. And we knew that coming into this pandemic, and we focused our efforts on equity to ensure that we wouldn't get the same level of inequity for this current COVID pandemic. And we're still working hard on that now. So according to the Ministry of Health, and this was taken at the end of October this year, this shows how much we've focused on ensuring we have the best possible outcomes with regard to equity and this COVID-19 pandemic. So many of the conditions facing Māori in 1918 still persist today in 2020. There's a huge variation in socioeconomic deprivation, and Māori represent a significant part of our poorest population in New Zealand. There is great variation by ethnicity and access to and quality of care, like there was back in 1918. And the incidence and prevalence of high-risk conditions continue today in 2020. So looking at the total cases by ethnicity, about 61% of our infections were European or other. Māori were around 9%, Pacifica were around 10%. So that's not too bad for Māori. Māori are 16.5% of the population, and only 9 percent of the infections. That's pretty inequitable though for our Pacific population. They are not 10% of the New Zealand population. They're around the 5 to 6% mark. So there has been great inequity in terms of infection and total number of cases for Pacifica. But thankfully, we haven't had that translate into mortality yet for Pacifica. In terms of testing, one of the ways to try and ensure we don't get inequity in terms of infection or more particularly in mortality and morbidity is to ensure that we over-test our most vulnerable populations. And we've certainly done that for Māori. If you look at the testing rate per 100,000 for Māori, it's significantly higher than all other population groups except Pacifica. And obviously Pacifica have had a really high infection rate in this pandemic, so their testing rate is also much, much higher. In fact, it's more than double, or it's close to double the general population. So that's very, very good. We're over-testing in those vulnerable populations to try and avoid an inequity in terms of mortality. And as you can see, the positivity rate for Pacifica is about the same as everyone else. Māori are much lower. So New Zealand tested at much higher rates for Māori and Pacifica, and this was appropriate given our history of unequal infection in previous pandemics and the greater risks faced by those populations. So far, the strategy has been successful, but as I'm sure we all know, this pandemic's got a long way to go before it plays out. But so far, our strategy has been good, and we've managed to avoid an inequity in terms of morbidity and mortality. So one of my favourite poets is Maya Angelou, and I particularly like this quote from her: "Do the best you can until you know better. Then, when you know better, do better." So, I roto I te reo Māori, and te reo Māori, pēnā e mohi o ana tātou ki te ara tika, tēnā me whai. And the reason I'm saying this here is I presented you with some data earlier about cancer and ischemic heart disease and so on, and looked at mortality rates. So we know lots of stuff about Māori, access to healthcare and the quality of healthcare that they receive. So what Maya Angelou is charging us with is, well, we must always do the best that we can. However, when we learn new stuff, when we know better, we should look to do better. So let's think about that more carefully. When we know better, do better. What do we actually know today in 2020 about Māori health equity? What is it we actually know? Where's our knowledge coming from? What does the evidence tell us? What do we know today? Well, we actually know quite a bit. If we look back on some of the publications here, in the year 2000, or 1999 to 2000, the Ministry of Health published a series of 3 bulletins called Decades of Disparity, and they looked at ethnic and socio-economic inequalities and mortality in New Zealand. And they noted that actually mortality, life expectancy at birth increased. It got worse between Māori and non-Māori during the 80s and 90s. That at the beginning of the 80s, the life expectancy gap between Māori and everyone else was 6 to 7 years. By the end of the 1990s, that gap had increased by some 2 years. So actually the gap got worse. Life expectancy gap got worse. Inequity got worse over that period of time. Throughout the 1980s and 90s, the mortality rates between low and high income groups increased over time, and these inequalities were rooted in historical social processes that entrenched the privileged position of dominant groups. So Māori and non-Māori inequalities in mortality persisted within socioeconomic strata. So this was 20 years ago, and the ministry looked at data for the previous 20 years, and they saw significant inequality, significant inequity between Māori and non-Māori back then. the University of Otago has the Wellington School of Medicine, which is part of the University of Otago, and the Wellington School of Medicine has a research centre called the Eru Pomare Research Centre, based in Wellington. And over a long period of time, since 1980, they have published a series of documents called Hauora. There have been 4 of them. Hauora 1 was published in 1980, and it looked at data from the years 1955 to 1975. Hauora 2 was published in 1988 and looked at data from 1970 to 1984. Hauora 3 published in 1995, looking again from 1970 but through to 1991. And Hauora 4, the most recent, was published in 2005, looking at data from 2000 to 2005. And all of those publications looked at various data within the New Zealand health system, and they all showed significant differences between Māori and non-Māori in terms of their access to services, the quality of care they received, and more particularly, their health outcomes. So over a period of some 40 years, the University of Otago, through its Wellington School of Medicine, has published literally volumes of data demonstrating health inequity that we know about in New Zealand between Māori and non-Māori. And there's a link to Hauora 4 there in this slide. In 2006, the New Zealand Family Health Physician published a study which concluded that Māori in New Zealand receive fewer referrals. They receive fewer diagnostic tests. They get less effective treatment plans than non-Māori. They're offered treatments at a substantially decreased rate. They are interviewed by their doctors for less time, and they are prescribed fewer secondary services. So the study concluded that Māori encounter a different health system to non-Māoris. So when I, as a Māori, enter the health system, I receive a different service, a different quality of service to my Pākehā wife, for example. It's intriguing that we knew this more than a decade ago, that Māori encounter a different health system to non-Māori. In recent years, the Waitangi Tribunal has been hearing evidence. It heard stage 1 of the Health Services and Outcomes Inquiry in 2018 and published its report in June 2019. And here are some of its conclusions from stage 1 of that inquiry. The New Zealand Health Framework fails to consistently state a commitment to achieving equity of health for Māori. The funding arrangements for primary health disadvantage Māori, both organisations and providers, and the Crown has been aware of these failures for well over a decade, but has failed to adequately amend or replace the current funding arrangements. And it goes on, there's a link to that report in the slide. It goes on to discuss a whole range of things, but what I'm highlighting here is there have been failures in our system. There are inequities in our health system. We know about these, we've published these data, and yet we still fail to respond. And just this year, the New Zealand Health and Disability System Review, and again, there is a link to the final report from that review, which was only published a few months ago. And some of the conclusions from that Health and Disability System Review: Māori experience of hospital services is characterised by poorer access, poorer outcomes, and being exposed to institutional racism. Hospital appointments are less accessible for Māori compared with non-Māori. 16% of Māori adults do not attend specialist appointments, and it was compared with 6% of non-Māori. And for Māori, deaths preventable by healthcare are 2.5 times as frequent as non-Māori. 2.5 times greater chance of dying by something that's preventable in the healthcare system if you are Māori than if you're a non-Māori. So the Māori health outcomes are significantly worse than those of other New Zealanders, and this represents a failure of the health system, and it was published in June of this year. So I go back to that question, and again it touches on what Maya Angelou said. What do we know today about Māori health equity, because Maya Angelou implored us, do the best that we can until we know better. When we know better, let's do better. So we actually know a great deal about Māori health inequity, and we have known for a very long time, literally decades and decades of data tells us how unequal our health system is, how poorly we treat Māori, how poor the access to health services for Māori is, and how different the quality of healthcare is that Māori receive. So we know about this. There are literally volumes of data published about this. And despite knowing this, we're not doing better. So why aren't we doing better? And I ask this question, do Māori lives really matter? Because if they mattered, why aren't we doing something about this? Why aren't we doing better? If we know that the funding arrangements are inadequate, why aren't we doing something about it? If we know Māori don't get access to health services, why aren't we changing that to ensure we get better access to health? And I guess this Māori lives matter, Māori lives really matter? I'm shamelessly piggybacking on top of the Black Lives Matter movement, because in New Zealand, that's actually what's relevant to us. And often the counter to that, people will say, well, actually all lives matter. So let me be really clear. Yes, all lives do matter. However, all lives matter is a spurious argument because context matters. And just looking at those graphics that you see in front of you there, not all of those buildings matter. Context matters. The house that's on fire matters the most. Not everyone's lives matter at the beach. If we're at the beach, actually if someone's drowning in the water, their life matters more than everyone else. The life that matters the most is the one drowning. Now those are two simple examples around why all lives matter is spurious, because when we look at the data for health in this country, what we see is Māori are drowning. Māori are on fire. Everyone else isn't. We are experiencing much worse outcomes than everyone else. We have been on fire and we have been drowning for decades, and everyone has known that we've been on fire and drowning for decades and let us drown and let us burn. So actually, I ask that question again, do Māori lives matter? Because if, as implored by Maya Angelou, we should be doing the best that we can until we know better, and then when we know better, we should do better. Well, actually, we know better now and we are not doing better. What's wrong with this picture? The systemic assumptions about equality are exacerbating inequity in this country because we are treating every building the same despite some being on fire and some not, because we are treating every person the same despite some drowning and some not. What's happening is Māori are drowning, Māori are catching fire, and we are missing out on the fruit. And actually something needs to be done about this in our health system. This fixation that we have with treating everyone the same, and I'll return to the National Bowel Screening Program, treating everyone the same and screening from the age of 60, despite the fact that we know the majority of Māori colorectal cancers occur before the age of 60, will ensure unequal outcomes for Māori. We know that now, we knew it before the bowel screening program was rolled out. The College of General Practice has written to the Ministry of Health, as has the College of Surgeons and the National Māori General Managers and the Māori Doctors Association have all written to the Ministry of Health saying you should not be treating Māori the same. The data tells you that they are different. They get the illness sooner and they die sooner. And despite this, we're still treating everyone the same. My plea is to have an equity approach and treat people differently based on the data we receive. And I think the key issue to understand around this is when you have an equity approach, nobody loses. But at the moment, our equality approach affords privilege to non-Māori in terms of access to services and their health outcomes. So it's no accident that Pākehā receive better access to healthcare and better health outcomes in Māori, because the system is set up to ensure that. And as uncomfortable as that sounds, we need to understand that this is a reality in the New Zealand health system. So I have a video here which I want you all to listen to by an English gentleman called Paul Scanlon, and just have a listen, and we'll talk about this shortly.
Some time ago, I was speaking at a corporate event in America. I was the guest speaker. That night at dinner, I was at a table full of white people, and the guy, one of the bosses who'd invited me, actually started to tell a joke that I knew straight away was going to be racial. And black people were going to be the butt of the joke. In those split seconds in the early sentences of the joke, I had a decision to make. Do I say something or stay quiet? No one else was saying anything, though I'm sure they felt uncomfortable. So I spoke up and I said, I don't think this joke is one I want to hear. I don't like the way it's going. I think it's going to be at the expense of black people. I'm not comfortable with that. Would you mind not telling it? Or I could leave the table. It was very uncomfortable. I remember he didn't tell the joke, but it was uncomfortable the rest of the night. Later in my room, I journaled what I felt about what was going on. I thought two things were at play. One was what I would call white solidarity. The other was what I would call white social capital. White solidarity is an unspoken code, I think, that we have as white people that means we would never embarrass each other by creating a racial discomfort for each other, by interrupting a racist joke or pointing out an act of prejudice or discrimination. We cannot keep quiet because it's a social code that we have, that we would remain in solidarity with each other, which protects our whiteness, our white advantage, our white privilege. That was at play at the table that night that allowed him to do what he'd done obviously many times. White social capital is what you get if you stay quiet. You get included, you are one of the boys, you are an insider, you are good to be around, you're a team player, you're fun, which may give you opportunities of inclusion as well in a corporate setting, a business setting, a social setting. It is an accruing of white capital by going along with it. I want to say to my white friends listening to this that our silence at those times is not benign, it is malignant, because we become complicit in the continuation of the racist joke telling. It gets told again and again because when we heard it, we didn't say anything. And as socially awkward as it is, and knowing you'll be penalized if you say something, I'm appealing to us, because millions of us every day have this opportunity to say something, to speak up, to stand up for people of color and black people. And you will be excluded and you will lose social capital, but you will be a champion of a cause that you wish someone had been for you at times in your life. And I think many of us feel we can't do anything at the large government level. We can't protest on the streets. We don't feel comfortable with this or that. Can you say something today, wherever you are in your life? Can you speak up? Because our silence is not benign. It is continuing the problem. We can all play a part like this every single day. Let's speak up. Let's play our part, is what I'm appealing for. Love you guys. Thank you.
So Paul Scanlon touched on this idea that if we sit back and allow things to continue, actually we are supporting the status quo, and supporting the status quo actually allows inequity to continue. If you sit back, you get social capital. However, it persists the unequal outcomes and the inequitable outcomes that, in this case in New Zealand, Māori receive. And there's a little quote here by Nobel Prize winner Elie Wiesel. We must always take sides. Neutrality helps the oppressor, never the victim. Silence encourages the tormentor, never the tormented. And it goes really to the heart of things. I've told you a whole lot of data here. If we turn a blind eye, if we walk past it, it will persist. The evidence for Māori inequity is long-standing, it's robust, it's persistent, it's pervasive, and it's compelling. If we are ambivalent, ambivalence is not benign. If you just let it slide, it will get worse, and we are seeing that today. It's quite disturbing the amount of times that we see data that we know will lead to unequal outcomes, will lead to inequity, and people sit there in silence. So ambivalence is not benign. In matters of justice, one cannot sit by and allow the status quo to continue. And that's really what Paul Scanlon was touching on there when he interrupted the racist joke. Yes, it's uncomfortable. However, it's necessary if you want to make change, because it's often those casual things that allow the system to continue, and that's what we see in the New Zealand health system. Indifference to an issue supports inequity. Inaction does not follow the evidence that we see published time and again in New Zealand. The existing system perpetuates what we know to be wrong in our system. Complicity with the status quo is malignant. So we do know better. We've seen the data. It's published time and time again. We do know better. So why aren't we doing better? Quality, fairness, bias, and inequity. I fully appreciate that questioning the fairness of our health system is an uncomfortable undertaking. The principle of care based on need is a core value for most health professionals, particularly in the context of life-threatening disease. None of us wants to believe that our health system, or those of us working in it, might discriminate on the basis of ethnicity. Yet, an honest look at the evidence makes it difficult to avoid this assessment. Māori encounter a different health system. We know that. We've known it for many years. We know it now. So the challenge for us is to actually stand up and challenge that and force the system to change. We have a wonderful health system in New Zealand, but it's imperfect. And we know about many of the imperfections that we have to have the courage to face those, to confront those imperfections and change them. Just like Kate Sheppard did back in the latter part of the 19th century, she challenged the status quo and she got universal suffrage vote for women. And yet more than 125 years later, we are still struggling to find true equality for our wahine. But we're a lot better off now than we were 125 odd years ago. But we need to challenge the system. It's a wonderful system. It's a very good system, but it's imperfect and it is full of inequity and privilege for those who have power and privilege. So, not to leave you all depressed about that, what are some of the things that you can do immediately? Well, firstly, stop normalising Māori inequity. Every day we see data which says Māori have worse outcomes of this, worse incidence, worse prevalence, much fewer access to services and so on and so forth. Let's just stop normalising Māori inequity. We know that it's there, so let's act to change that. Stop blaming Māori for colonisation, deprivation and poor health. It's not someone's fault, and in particular, it's not Māori. It's not the fault of Māori. It is what it is, so let's work to change that. Let's all take responsibility for the things that we are able to control and influence. And in many cases, that's how people access our services and the quality of care that they receive. So if we know, for example, that Māori receive fewer prescriptions, and we do know that because Pharmac has published data on that, then let's see prescribers in this country examine themselves around that and ensure that there is no difference, or indeed, if there needs to be greater access for services, that changes. Know what your service should expect to see by ethnicity. If our population of Māori in New Zealand is 16.5%, then I would expect to see that across the country in terms of presentations. In some populations, though, it's much, much higher. Our proportion of young people is much, much higher, so we should see that in terms of access to services. And if we don't see that, we should seek advice and make changes to our service to ensure that we see the appropriate presentations and access to services. Let's not perpetuate the practice of treating people equally if the data, if the evidence shows that this will exacerbate Māori inequity and will afford privilege to non-Māori. So be courageous and challenge the way we shape our system. monitor performance towards equity, and make us all responsible for achieving equity. Don't just look at the Māori in our system and say you should improve equality, because 99% of all the data and resources, of all the money and services, goes to non-Māori. So shine a spotlight on the non-Māori part of the system and make them responsible for improving equity. And a nice simple piece of advice, I know it's hard to do, but intervene sooner and more often with Māori. You want to change inequity, think about how you can intervene sooner and more often with our Māori population, whatever service that may be. So what other things can we do, can I do? There's no single solution to this. I certainly appreciate that. One of the things you can do is assume that you'll probably get it wrong for Māori. And the reason I say this is if you walk into any situation, into a service or a planning meeting or whatever it may be, immediately assuming that you'll probably get it wrong for Māori, you will stop, you will pause, and you will think in different ways. And this will drive you to reflect and engage in different ways to ensure that you have Māori voices around the table and do better for Māori. Don't be complicit. Speak up when you see, hear, or experience bias. Another simple piece of advice is say kia ora at every opportunity. I love what Air New Zealand has done over the last decade to transform themselves, and I appreciate that it's been pretty tough in a pandemic environment where people are flying less, but look what they've done for the use of Te Reo Māori on our national carrier. Why can't we do that in our national health system? Say kia ora all the time. And the reason that's important is because kia ora belongs to us here in Aotearoa. You won't hear it in any other place in the world unless people are doing it because they're Kiwis living overseas. It belongs to us. But when you look at the history of colonisation in New Zealand and the Native Schools Act, which prevented Te Reo Māori from being used as a language of instruction within our schools, you'll appreciate that our country tried to stop Te Reo Māori being spoken. Now, we've changed that in the last decade or so, but we need to change that even more. And saying kia ora, using Te Reo Māori more often sends a really powerful message to Māori that the system sees you, it hears you, it understands you, and it welcomes you. And we haven't always been that way in our health system. Use Te Reo Māori at every opportunity, not just kia ora. If you know words in Te Reo Māori, if you know things like kei te pai, kei te pēhea, koe, kōrero, mahi, hui, use those words as often as possible. Use them in your emails, use them on your telephone. Try more and more to use Te Reo Māori, because every time you do it, you give permission to others to use it. You make it more acceptable, and you send that message to Māori that we see you, we hear you, we're doing our best to understand you, and we welcome you. And pronounce it correctly. And if you don't know how to pronounce it, learn, and when you know better, do better. Use Hauora Māori services when you can. Don't rely on them. We need everyone to be more culturally competent and more culturally responsive. But when you're not sure, seek advice from Hauora Māori services. They will help you out. When you know you're saying something wrong, do it. Do better. And that applies to our place names, someone's surname, whatever it may be. When you know better, do better. Support your Māori staff and whānau in your team and in your service. Help them grow and develop our own Māori workforce to do better. If we want to change inequity, we have to do stuff. We have to be active about improving access to and quality of healthcare. We can't just say it, we actually have to do stuff. Which leads me to a well-known whakatauki, a well-known proverb in Māori. All of this data isn't to beat people up. All of this information isn't to beat people up. It's to challenge us all. He mana ko te koura I kore ai. Wishing for crayfish won't bring it. You can't be just sitting around waiting for the crayfish to occur. If you want crayfish, you actually have to get off your backside, get into the water, and find those crayfish. If you want equity, you can't keep doing the same thing. We actually have to get off our backsides, look at the data, challenge ourselves, be confronted by what we see, and make changes in order to get better health outcomes. And if that means testing more Māori, getting more Māori in, ensuring that we have Te Reo Māori all over the place, ringing our Māori patients in whānau, whatever that may be. We need to do things differently in order to get better health outcomes for Māori, because the system hasn't worked so far. It perpetuates inequity. So why am I saying this? There's another old Māori saying, which I think many of you have probably heard before, hutea te rito o te harakeke. If you rip out the centre of the flax, kai hea te koma ko e ko, where then will the bellbird fly? Ki mai kia hau, you say to me, he aha, te mea nui o te ao. What is the most important thing in this world? Mā ku e kia atu, and I will say to you, he tangata, he tangata, he tangata. So the most important thing in the world, he aha te mea nui o te ao, he tangata, he tangata, he tangata. What's the most important thing in the world? It is people, it is people, it is people. And if we see in Aotearoa, in New Zealand, a group of people who are suffering, who have suffered with health inequity for decade after decade after decade, and we know this, and we fail to act, then we are complicit in that inequity. Now that we know, we have to make changes to improve that. Because if we truly mean that people are the most important thing in the world, then we have to act for our most vulnerable, those who have the worst health outcomes. And in line with that particular whakatauhi, that saying, hea te mea nui o te ao, here's a little video from te kura kaupapa Māori o te whānau tahi, the kura kaupapa Māori that my children went to and now that my mokopuna goes to. Have a listen to this. Kia ora koutou, thank you for listening to my presentation. And as a call to action, my plea to everyone listening and watching today is to think carefully about what it is that you and your team and your services can do in terms of changing these unequal inputs and unequal outcomes that Māori experience. So how can you engage better with Māori patients, whānau and communities, get those voices around the table, seek their views around what is needed and what they can do to support you to deliver better services in terms of advanced care planning. What is it that we can do collectively, but individually as well, to ensure that more Māori know about this, get engaged in this, and spread throughout their community and their whānau and their hapu and their iwi, so that they have greater opportunities to engage with this particular kaupapa and get better access to that service to enjoy the same privileges of outcome that others in our community experience. So think about it. There isn't a single answer to this. There isn't a golden bullet to it. But what you must ensure is that more Māori voices are heard and we engage better. And when you think you don't know, you probably don't. So send those pointers out into the community. Ask your Māori colleagues, go into your Māori community, engage better with Māori whānau and communities, and they will have the answers for you. And like I said before, assume you'll get it wrong for Māori, because you probably will, and that will make you think in different ways. So, kia ora tātou, nei rā te mihi anō kia koutou, tēnā koutou, huri no, tēnā no tātou katoa.